Welcome to the deep dive. Today we're plunging into, well, a really significant area for vascular specialists, acute limb ischemia, or ALI.
That's right. It's when a limb suddenly loses its blood supply. And the speed and accuracy of diagnosis and treatment are absolutely paramount.
Yeah, absolutely critical, unlike some vascular conditions where the treatment path might be a bit more straightforward.
Exactly. ALI throws a lot of different causes, different potential solutions at us.
So to really get a handle on it, we'll be drawing on the expert knowledge found in Rutherford's vascular surgery and endovascular therapy.
It's a definitive source.
Okay, so let's unpack this. Our goal today is to dissect the various ways ALI can occur, its underlying causes. Then we'll explore how it shows up, how clinicians assess and diagnose it, the methods they use to classify severity.
The initial management steps, which are crucial.
Right, and then the different treatment avenues, meds, surgery, endovascular stuff, and even how recent global events have played a role.
It's a lot to cover.
It is. And what's fascinating, like you said, is there's no single silver bullet treatment. It's all about understanding the nuances.
Precisely. We need to appreciate that ALI isn't usually just one simple thing. Often multiple factors are interacting, and the best path forward isn't always immediately obvious.
Which is why that deep understanding of the causes, the etiology, is so critical.
Exactly.
So let's start right there. What are the primary drivers? What causes acute limb ischemia?
Okay, well, the textbook points to two main non-traumatic origins: arterial embolism and arterial thrombosis.
Embolism and thrombosis.
Yeah, and while figuring out which one it is can be important for, the bigger picture prognosis and stuff, it doesn't always dictate the immediate right-now treatment strategy.
Interesting. Okay, let's start with embolism then. What exactly happens there?
So think of an embolism as a blockage that's, taken a trip through the arterial system.
Okay.
An embolus is a piece of material, could be a blood clot, maybe plaque, something else that breaks loose from where it started, travels downstream, and then gets lodged in a smaller artery, blocking blood flow.
And where does this traveling material usually come from?
The most common source, the heart. Often it's a mural thrombus, basically, a clot stuck to the heart wall that breaks free.
Okay, heart's the main culprit.
Or another big one is atherosclerotic debris, bits of fatty plaque or clots from larger arteries closer to the heart, like the aorta. They can shear off and travel down.
That sounds pretty dramatic. Where do they tend to get stuck?
Well, they usually lodge at arterial bifurcation spots where an artery splits into smaller branches. It's just physics. The vessel narrows there.
Right.
So in the legs, common spots are the common femoral artery up in the thigh and the popliteal artery behind the knee.
Okay.
In the arms, often the brachial artery. And then rarely, but catastrophically, you can get a big saddle embolysis blocking the whole aortic bifurcation where the aorta splits for both legs.
Wow, a saddle embolus. That sounds major. What happens immediately when an embolus hits?
Well, because these often happen in arteries that were maybe okay before, they haven't built up those alternative routes.
Collateral circulation.
Exactly, the collaterals, like detour roads the body sometimes builds. So when the blockage hits suddenly, bam, it can be very severe.
And that's the white leg.
That's the classic white leg. The limb goes pale, cold, and there's a really significant fast loss of sensation and movement. Very sudden.
A white leg.
Yeah.
Yeah, that really paints a picture. And the problems don't just stop with that initial blockage, do they?
No, unfortunately not. That first embolus often triggers more clotting, secondary thrombus, both upstream and downstream from the blockage. That's the sort of plum-colored clot surgeons often pull out during an embolectomy. And dealing with that secondary clot is vital because it blocks things up even further down.
Right.
And if you delay treatment, that secondary thrombus gets stickier, harder to remove. It just shows how dynamic this whole process is.
You mentioned the heart as a big source. What specific heart conditions really up the risk?
Yeah, several things. Atrial fibrillation, AFib, is a huge one. That irregular heartbeat lets blood pool and clot, often in the left atrial appendage.
Okay, AFib.
Then there's mural thrombus, like we said, often after a heart attack damages the muscle. That clot can break off, high risk.
Makes sense.
And a left ventricular aneurysm, a bulge after a heart attack. Same idea, sluggish flow in the bulge, clot forms, then travels. It's all about areas where blood isn't flowing smoothly.
So a lot hinges on the heart muscle itself and the rhythm.
Absolutely. Historically, heart valve disease was a massive cause.
Right.
But now, with better management, it's less common. Patients with prosthetic valves are usually anticoagulated.
Yeah.
Pig valves, porcine valves have a pretty low risk.
Okay. What about when the clot doesn't start in the heart? You mentioned paradoxical embolism earlier.
Ah, yes, paradoxical embolism. It's fascinating, really. A bit unusual.
How does that work?
So a clot forms in the veins, usually a DVT in the leg, but then it takes a wrong turn, basically.
Into the arteries.
Exactly. If the person has a hole between the heart's upper chambers, usually a patent-forming ovale, a PFO, that venous clot can cross over from the right side to the left side of the heart, especially under certain pressure conditions, and then boom, it's in the arterial system, causing an arterial embolism.
Wow.
We get suspicious of that in younger patients, especially if they have an arterial blockage and a DVT at the same time. It's a clue.
Definitely less common.
Yeah.
Any other maybe less obvious heart-related causes?
Yeah, less frequent, but important. Bacterial endocarditis infection of the heart lining or valves.
Okay.
Those infected clumps, vegetations, can break off. Higher risk for IV drug users, patients with lines, immunocompromised folks.
Right.
And also a benign heart tumor, an atrial myxoma, usually in the left atrium. It can be fragile, bits break off, embolize. So if the surgeon finds weird-looking material during embolectomy, or it's a young patient with no clear cause, they'll often send it for histology.
Good to know. Okay, so that's the heart covered. What about non-cardiac embolism? Atherosclerosis plays a role there too.
Yes, definitely. Atheroembolism. That's a big non-cardiac cause.
So plaque breaking off?
Exactly. Fragments of plaque or clots forming on that plaque in big arteries like the aorta. They break loose, travel down, and can look just like a cardiac embolism.
Right.
The material might just be clot, or it could be actual hard, calcified plaque bits, atheromatous plaque. That stuff's harder to remove and can cause really nasty, irreversible blockages way down in the small vessels.
And this can just happen spontaneously? Or is it triggered?
Both. Can happen spontaneously as the disease progresses, or it can be triggered by procedures, like fiddling with catheters inside arteries during heart cath or other interventions.
Okay. And you also mentioned clots forming right on the aorta wall, even without bad disease.
Yeah, aortic mural thrombi. It's rarer, but happens in hypercoagulable states when the blood clots too easily. A clot forms right on the aorta lining, even if the aorta isn't terribly diseased. If that breaks off, it embolizes. You might suspect it if the patient doesn't have typical risk factors and the heart checks out okay. And the treatment for that underlying aortic clot might just be anticoagulation.
Okay, that's a great overview of embolism. Let's switch gears to the other main cause. Thrombosis. Clot forming within the artery itself. How does that lead to ALI?
Right. Thrombosis, basically a blood clot forming right there in the artery. Couple of main reasons.
Okay.
The artery might be getting narrower and narrower from atherosclerosis.
No plaque buildup.
Exactly. Or the blood itself might be too prone to clotting hypercoagulable state, or sometimes related to an arterial dissection, which we can talk about.
So atherosclerosis, that plaque buildup, is a really common cause of thrombosis,
Right.
leading to ALI, especially in the legs.
Absolutely. In leg arteries, that progressive narrowing is the most common underlying issue.
Right.
As it gets critically narrow, flow slows down, conditions are right for a clot to form right there, and eventually it blocks off completely.
But the presentation can be different from an embolus, right? Less sudden.
Often, yes. Because the narrowing happens gradually, the body sometimes has time to build those collaterals, those detours. So instead of the sudden white leg, maybe it's more of a stepwise worsening. Like claudication, that pain with walking gets acutely worse. Maybe improves a bit as collaterals kick in, but then eventually progresses to critical ischemia as blockages get worse or happen at multiple levels. It's often more insidious.
Makes sense, the body trying to adapt. What about the idea of a plaque suddenly rupturing? Does that happen in leg arteries too?
Well, we know plaque rupture is a big trigger for heart attacks and strokes.
Right.
It's plausible that a similar thing, sudden plaque disruption, could trigger acute clot formation on top of chronic disease in leg arteries, too. We just don't often get to examine the artery wall directly in the same way. But yeah, it's likely a factor in some acute on chronic thrombosis cases.
And what about people who already have significant peripheral artery disease? Can something else tip them over into ALI?
Yes, definitely. If someone already has bad narrowing in their leg arteries, a sudden drop in their overall blood pressure or flow.
Like from shock or a heart problem?
Exactly. Septic shock, low cardiac output from a heart event that can precipitate acute limb ischemia. The already compromised flow just becomes totally insufficient because of the global hypoperfusion.
So the problem isn't a new clot in the leg, necessarily.
Not primarily. It's the whole system failing to deliver enough blood. Recognizing that is key because you have to treat the underlying critical illness first.
Okay, crucial distinction.
Yeah.
You also mentioned hypercoagulable states, blood clotting too easily causing thrombosis.
Yes. Sometimes a clot forms in situ right there in the artery, even without much atherosclerosis, just because the blood itself is too sticky. These states are more linked to DVTs, venous clots, but some conditions like thrombocythemia, too many platelets, can cause arterial clots, often in smaller vessels. There's also a known link between arterial thrombosis and underlying cancer.
Really?
Yeah, so if someone gets ALI without obvious atherosclerosis, screening for malignancy might be considered. Though sadly, the prognosis often isn't great if it's linked to advanced cancer. And we have to remember things like heparin-induced thrombocytopenia, HIT, paradoxically getting clots while on heparin, and a whole range of other clotting disorders.
So it's not always just the plumbing. Sometimes it's the fluid itself.
Exactly.
Okay, what about less common causes? Vasospasm.
Primary Raynaud's rarely causes full-blown ALI. But secondary Raynaud's, linked to things like scleroderma, can sometimes cause acute digital ischemia fingers or toes.
And the treatment there?
Often vasodilators, prostanoids, drugs to relax the blood vessels. We also see digital ischemia from, unfortunately, illicit drug injection into arteries. Nasty stuff. Treatment involves anticoagulation, maybe thrombolytics, and again, vasodilators.
You also mentioned aortic dissection briefly. How does that cause limb issues?
Right, aortic dissection. A tear in the aorta's inner lining. Critical emergency.
Yeah.
If that tear extends down to where the aorta splits for the legs, the bifurcation, it can block flow to one or both legs. Looks like an iliac artery blockage.
What are the clues for dissection?
High suspicion if the patient has leg ischemia plus sudden severe chest or back pain. Maybe high blood pressure too. And if it involves the renal arteries, you can get acute kidney failure.
Scary stuff.
Very. Dissection further down in the leg arteries is uncommon, usually related to trauma or conditions like fibrodysplasia.
And lastly, cause-wise, blocked bypass grafts.
Absolutely. As bypass surgery becomes more common, graft occlusion is an increasingly frequent cause of ALI, especially in areas with good vascular services.
And that's usually thrombosis in the graft.
Mostly, yes. Thrombosis within the graft itself. Diagnosis is usually easy. Patient knows they had the bypass. But figuring out the best way to treat the blocked graft can be complex, lots of options. But the general approach is similar to native vessel ischemia.
That's a really thorough rundown of the causes.
Yeah.
So, moving on. How does ALI actually present? What are the key signs and symptoms clinicians look for?
Well, the presentation really depends on two big things: which artery gets blocked, how big it is, and how much collateral flow, those detour routes, the patient already had.
Right.
Like we said, sudden blockage high up, no collaterals, classic white leg. But block a smaller artery, like the SFA in the thigh with good collaterals already, might be mild symptoms or even none. It's a spectrum.
So it's not always super dramatic.
Exactly. The textbook highlights that sensory nerves usually get hit first. So new or worse numbness. Tingling, that can be an early sign.
Okay.
Then motor nerves go next, muscle weakness. And ultimately, if flow isn't restored fast enough, skin and muscle damage becomes irreversible. Muscle tenderness, especially in the calf, is usually a later, more severe sign.
And visually, what changes do you see in the limb?
Initially, it may be pale white skin, but then as capillaries dilate trying to compensate, it can turn dusky, bluish cyanosis. If you press on that blue skin, it still turns white. Temporarily, it blanches. But a really bad sign is when the capillaries start leaking blood into the skin. Then, if you press it, it doesn't blanch. That means the skin's not viable.
Wow.
And trying to revascularize tissue that's already necrotic risks big problems, compartment syndrome, kidney failure, without saving the limb.
So recognizing these signs early and their meaning is absolutely critical.
Totally. And the textbook also mentions that historical shift. Used to be more valve disease causing emboli in otherwise healthy arteries.
Right.
Now it's more often AFib with underlying heart disease and atherosclerosis. So older patients, often with pre-existing artery narrowing, makes the picture more complex, maybe an embolus on top of chronic disease.
And with an aging population.
We're seeing more ALI overall. These shifts change the challenges.
Given these complexities, a thorough, timely assessment is obviously key. What does that involve?
It's really two parts: examining the limb very carefully and assessing the whole patient, their history, risk factors.
Okay, let's start with the history. What specific info are you after?
Onset and nature of symptoms are key. Is it mild pain or total loss of function? Severe pain, numbness, weakness usually brings people in fast.
Right.
Less severe cases can be tricky, maybe mistaken for sciatica or muscle strain. Duration is vital. Severe ischemia. Irreversible muscle damage can start in just 6 to 8 hours.
Wow, that fast.
Yeah. That white leg needs immediate action. Sensory loss, muscle pain, those scream critical ischemia.
And you're also trying to figure out the likely cause from the history.
Absolutely. Does the patient have atherosclerosis already? Maybe suggest thrombosis. History of prior claudication points towards acute on chronic thrombosis. Full medical history, diabetes, other conditions. And always ask about risk factors. Smoking, hypertension, high cholesterol, family history, all clues.
Okay, then the physical exam of the limb itself. What are the key findings?
Meticulous exam is crucial for staging the severity. The classic 6Ps are still a good guide.
Pain, pallor, paralysis, pulselessness, paresthesia, perishingly cold.
You got it. Pain, pallor, paleness, paralysis, weakness, toes movement, pulse deficit, paresthesia, numbness, tingling, and poikilothermia, coldness.
Okay.
We look closely at skin color. Marble white, total ischemia. Check capillary refill time slow, suggests some distal flow, might still be there. Test fine touch and proprioception, knowing where your foot is without looking. Those go early. Muscle tenderness, especially the calf. Advanced ischemia. And feeling for pulses tells you the level of blockage. Normal pulses on the other leg might suggest an embolus.
And you need to check pulses all the way down, right? Not just the foot?
Absolutely. Full vascular exam. Feel from the groin down, helps pinpoint the occlusion level, though beware the water hammer effect.
What's that?
A strong pulse felt just before a total blockage can be misleading.
Yeah.
Also, look for sources aortic or popliteal aneurysm. Listen to the heart AFib. And remember, these patients are often older with comorbidities. The overall physical exam helps predict outcome too.
You mentioned handheld Doppler ultrasound earlier. How does that help?
It's invaluable at the bedside. In the bad leg, foot signals might be gone or weak.
Okay.
Normal biphasic signals, that two-part sound, pretty much rules out a major blockage above where you're listening. Soft monophasic signals, one tone suggests a blockage upstream, but maybe the vessels down low are still open. No ankle signals at all. That's a poor sign. Either tiny flow or total thrombosis down there.
Can you measure pressure with it?
Yes, but in severe ischemia, ankle pressures might be unmeasurable. Less severe, maybe 30-50 millimil Hg, ABI around 0.3 suggests subcritical acute ischemia. You can even check the veins. No popliteal vein signal is a bad sign alongside arterial ischemia.
So putting the history, exam, and Doppler together, you can often figure out where the blockage is.
Yeah, pretty reliably. An aortic occlusion, usually obvious. Both legs paralyzed, patient looks sick, modeling up to the groin, no pulses below that, high risk especially for kidneys, could be dissection involved.
And iliac occlusion?
Similar, but usually just one leg. No femoral pulse on that side, modeling to the groin. Still need to think about dissection if the story fits.
Femoral popliteal, below the groin.
Most common location. Severity depends if the profunda femoris, the deep femoral artery, is open. That's a key collateral. Might still feel a strong femoral pulse, that water hammer thing.
And blockages further down, like behind the knee or lower leg.
Popliteal and infrapopliteal. Calf muscle ischemia, but might still have femoral, maybe even popliteal pulses. Rarer causes in young folks here. Entrapment, cystic disease. But a sinister cause is a popliteal aneurysm, clotting off or sending clots down.
How do you spot that?
Suspect it if you feel a really big bounding popliteal pulse in either leg or a non-pulsatile mass behind the knee. Outcome can be poor because of chronic showering of small clots before the big one hits. Tibial emboli are less common. Most symptomatic ones are bigger, lodge higher up. Harder to treat down there too.
Very helpful anatomical guide. Okay, so you suspect ALI. How do you formally classify how bad it is? I gather the old thrombosis versus embolism classification isn't the main thing now.
That's right. Trying to definitively prove the cause acutely is often hard. And more importantly, what really drives immediate management is how threatened the limb is.
Makes sense.
So current classification systems focus on the severity of the ischemia itself. That guides urgency, predicts outcome much better.
And what's the standard system used?
It's the Society for Vascular Surgery International Society for Cardiovascular Surgery system, refined a bit by TAPC in 2007. Basically defines ALI as any sudden drop in perfusion threatening viability.
Okay.
It uses clinical findings and Doppler measurements, stuff you can do quickly at the bedside. The core categories are pretty stable.
What are the categories?
3 main classes. Class 1 is viable. Limb isn't immediately threatened, maybe acute onset claudication. Aggressive treatment like thrombolysis might be riskier here. Conservative approach might be better initially exercise, medical therapy.
Okay, class 1 is viable. What about the other end?
Class 3 is irreversible. No hope of saving the limb. Trying to revascularize risks systemic problems like rhabdomyolysis. Decision is usually amputation versus palliative care.
And the middle ground.
That's class 2, threatened. Needs intervention to save it, and this is subdivided.
Uh-huh.
AFib is marginally threatened or acute subcritical ischemia. AFib is immediately threatened, acute critical ischemia.
And the difference is crucial for timing.
Absolutely. AFib needs urgent treatment. Delay risks irreversible muscle damage, limb loss. Act fast. The limb's at risk, but you usually have a bit more time for investigations, planning a semi-elective intervention.
What clinically separates II from II? What makes it immediately threatened?
3 key things. Pain at rest in the limb, sensory loss, numbness, decreased sensation, and muscle weakness or paralysis. If those are present and significant, it points to II immediate jeopardy. Milder or absent findings lean towards II.
Got it. So, based on this classification, what's the ideal pathway of care?
Well, outcome really depends on getting prompt, appropriate treatment and where you get it. Best results are in specialized vascular centers, 247 coverage, full facilities.
Right.
European guidelines, for instance, say if ALI is diagnosed in a non-vascular center, transfer to a vascular center ASAP. Especially urgent transfer for that class II critical ischemia. Time is tissue, time is muscle.
Timely transfer is key. Once at a specialized center, what further investigations happen?
Investigations confirm the diagnosis, map out the blockage precisely, and plan the treatment. Although,
Yes.
if it's a class IB, immediately threatened limb, you might not have time for lots of imaging before needing to intervene urgently, surgically, or endovascularly.
So you might go straight to the OR.
Potentially. You might do on-table angiography dye injection during the procedure to guide things. Ideally, these patients go to a hybrid operating room equipped for both open and endovascular work.
Makes sense. But assuming there is time, what are the main imaging tools?
Computed tomographic angiography CTA has really become the workhorse in the ER setting for ALI.
Why CTA?
It's fast, widely available, gives great 3D images of the arteries using IV contrast. Very good for aortoiliac disease, good enough for below the groin too.
Any downsides?
The contrast dye can affect kidneys, especially if they're already weak, so we often hydrate patients well with IV fluids.
Okay, what about ultrasound? Duplex?
Duplex is great for chronic disease and can be useful acutely too. Find the blockage level, check collaterals. Might not be available 24/7 everywhere, but portable machines allow rapid bedside scans by specialists.
And traditional arteriography. Injecting dye directly. Still used.
Used to be the main diagnostic tool. Now, with CTA being so available and fast, diagnostic arteriography is less common initially.
So when is it used?
Its main role now is often during an endovascular procedure, confirms the diagnosis, gives a real-time roadmap right before you treat it with thrombolysis, thrombectomy, angioplasty, whatever.
Right.
If femoral pulses are gone, might need brachial access in the arm. It can also give clues. Lots of collateral suggests thrombosis. Multiple discrete blockages suggests emboli.
What about MRI?
Magnetic resonance angiography. Less useful acutely.
Well,
Often not available 24/7, takes longer, can be tricky for sick patients with monitoring gear. Practical limitations often favor CTA or ultrasound first.
and echocardiogram, ultrasound of the heart, what's its role?
It debated for immediate management. Often doesn't change the acute plan, as most embolic patients get anticoagulated long-term anyway.
But sometimes indicated.
Definitely. If you strongly suspect a cardiac source valve vegetations, PFO, tumor, but it has limitations operator dependent, can't always see the left atrial appendage well, not finding a source doesn't rule it out.
So a pragmatic approach.
Yeah. Consider it in young patients after revascularization if you strongly suspect a specific cardiac issue or if results might really change long-term anticoagulation plans.
Okay, diagnosed, severity classified, maybe cause identified. What are the critical initial management steps?
Right. Once you've diagnosed and classified, several immediate things need to happen.
Starting with anticoagulation, blood thinners.
Yes. Immediate anticoagulation is vital, especially with emboli. prevents the clot getting bigger, stops new clots forming downstream.
What do you use?
Typically intravenous unfractionated heparin calcium hepion. Its big advantage is it's rapidly reversible with protamine if urgent surgery is needed. Low molecular weight heparin is great elsewhere, but reversibility is key here.
Yeah, you monitor it carefully.
Absolutely. Weight-based protocols get you started, but you need to monitor the APTT blood test if surgery isn't immediate, aiming for a target range. Can't just assume it's working. Responses vary.
What other supportive measures?
Oxygen by mask might improve skin perfusion. 4V fluids patients are often dehydrated, plus kidney protection if contrast is used. Monitor urine output, baseline blood's kidney function, blood count.
Thrombophilia screen for clotting disorders.
Consider it if there's a strong history, but heparin messes up some tests, so ideally draw blood early. And crucial, good pain relief. 4V patient-controlled analgesia, PCA, is often good. Avoids intramuscular shots if thrombolysis might happen.
Okay, initial steps done. What are the actual treatment options to restore flow?
Main options are anticoagulation alone, open surgery, or endovascular interventions like mechanical thrombectomy or thrombolysis.
No.
The choice depends on the patient, the limb severity, the likely cause, and crucially, local expertise and resources.
Let's start with anticoagulation as the only treatment. When is that enough?
Well, heparin stops clots growing, prevents new ones, but doesn't dissolve existing ones.
Okay.
So using it alone is usually for cases where the limb seems likely to survive anyway, like stable class 1, or if other options are just too risky for the patient age, comorbidities. Historically, anticoagulants were a huge leap forward from just supportive care and amputation. And for stable class 1, acute claudication, anticoagulation alone can be safe, maybe followed by elective intervention later if needed. It also helps after embolectomy. And it's used in class 3 irreversible cases while waiting for amputation. But for most threatened limbs, it's part of the plan, not the whole plan.
Got it. Now, open surgery. The Fogarty catheter was a game changer.
Absolutely. Fogarty embolectomy catheter, 1963. Balloon tip, pull the clot out through a small incision. Made surgery the main treatment for years, especially for emboli.
But things have changed.
Yeah, disease patterns changed. Now we see emboli in patients with underlying atherosclerosis too. Makes embolectomy trickier, results less predictable, especially for acute thrombosis in diseased arteries. So bypass surgery rerouting flow is used more often now.
Right.
Modern vascular surgeons need the full toolkit, open bypass, and endovascular skills in a specialized setting.
And those endovascular options are becoming more central.
Definitely. Mechanical thrombectomy using devices to suck out or break up the clot can work well, especially for blocked grafts in expert hands. Less invasive, if it doesn't fully work, can follow with surgery or thrombolysis.
And thrombolysis. Clot-busting drugs.
Yeah, percutaneous thrombolysis. Deliver drugs right to the clot via catheter. Well established. Potential advantage is it might dissolve clots in tiny distal vessels that surgery can't reach.
So with all these options, how do you choose? Surgery versus endovascular?
Complex decision. Depends on local expertise, and crucially, the Rutherford class, the severity. Interestingly, big reviews haven't found a clear winner between surgery and endovascular thrombolysis for major outcomes like amputation or death.
No definitive answer.
Not universally. Some registry data, like SWEDVASC, hints at maybe lower mortality with endovascular first without more amputations, but endo might cost more overall, and open surgery still has significant risks around 20% morbidity, 22% limb loss risk.
Sounds like it really needs tailoring.
Totally. Severity guides it. Class I stable. Anticoagulation may be enough initially. Class I IB critical. Emergent revascularization needed, ideally in a hybrid OR with all options ready.
And if you go endo for IB, time is still critical.
Yes, no delay. Mechanical thrombectomy can be great if you have the kit and skills. Standard slow thrombolysis is usually contraindicated for IB takes too long, 12 to 24 H'ers, maybe accelerated lysis protocols in expert centers.
What about class 2, stable but threatened?
More options, more time for discussion. Multidisciplinary team approach is best. Obvious, accessible embolus, maybe simple embolectomy is best. Otherwise, main alternative to surgery is thrombolysis, maybe with mechanical help.
Lots of debate there, thrombolysis for surgery.
Huge debate. Big trials like TOPIAS looked at it. Enthusiastic centers report good lysis results. But meta-analyses don't show consistent differences. Guidelines basically say both surgery and endo are reasonable options.
So how to decide for II?
Good surgical option in a fit patient might be best, but many ALI patients are frail, high surgical risk. Thrombolysis might be better for poor surgical candidates, or if distal vessels look really bad, though lysis results aren't great in very high-risk patients either, highly individualized.
Given all this, what's the overall prognosis after ALI treatment?
Unfortunately, often guarded. The patient's overall health at presentation is a big predictor of survival. Recent heart attack, poor cardiac function, higher mortality risk. We can use scoring systems like POSSUM to predict risk. Even with successful limb salvage, long-term outcomes can be poor future cardiovascular events, mortality. And sadly, in some very elderly, comorbid patients, especially already hospitalized, ALI can be an end-of-life event, agonal thrombosis. Palliation might be more appropriate.
And mentioned cancer, too.
Yeah, another high-risk group is ALI due to hypercoagulability from advanced cancer. Initial results might be okay, but prognosis depends on the cancer stage. Many succumb within 6 months, even with active limb treatment.
We've focused on legs. What about the arms? Acute upper limb ischemia? Big differences.
Yes, several key differences. Patients tend to be a bit older, average age 74 or so.
Okay.
Arm ischemia rarely threatens limb loss like leg ischemia does, so treatment is often less urgent. Main goal is preventing late problems like arm fatigue, pain with use.
And the cause?
Mostly cardiac embolism. Atherosclerosis is much rarer as a cause of acute occlusion in arm arteries compared to legs.
How do they present?
Often coldness, numbness, tingling, rather than severe pain. Diagnosis is clinical, confirmed by duplex ultrasound usually. Unless it's immediately threatened, rare, then maybe straight to intervention.
Does it get better on its own?
Stable cases often improve with anticoagulation alone, making the decision for embolectomy tricky sometimes. But up to half might get late pain or problems if untreated.
So when do you intervene?
If the arm is clearly threatened, AFib, or if future function is critical, like the dominant hand, brachial embolectomy is often done under local anesthesia. Endovascular options are increasing here too.
And the outcome?
Limb loss risk is low, but concerningly, up to 20% don't survive the acute event, usually due to heart problems. And long-term survival isn't great either, maybe 60% at 3 to 5 years in one series, significant attrition.
Any unique causes in the arm?
Rarer things like thoracic outlet syndrome, compressing vessels, subclavian artery aneurysms. Also, AV fistulas for dialysis can thrombose or form aneurysms causing hand ischemia.
Finally, the COVID-19 pandemic. How did that impact ALI?
Yeah, COVID definitely changed things. We know vascular clotting events are a feature of severe COVID.
Did ALI rates go up?
Reviews suggest, maybe not significantly, but managing ALI in COVID-positive patients is definitely trickier. Younger patients might be affected more, and outcomes seem worse if infected.
So standard care still applies, but with extra considerations.
Exactly. 3 key things recommended. 1, CTA before revascularization should include the whole aorta and iliacs. 2, high suspicion for COVID, early testing, protective measures. 3, prefer local or regional anesthesia over general if possible during procedures.
And thromboprophylaxis.
Yeah, high-risk COVID patients should get prophylactic anticoagulation, may reduce both arterial and venous clots.
That's a really important timely update. So bringing this all together, it's crystal clear. ALI is incredibly complex, a major challenge.
Absolutely. We've covered the diverse causes, the critical need for fast, accurate assessment, the whole range of treatments.
And the key takeaway seems to be that the best strategy is highly individualized, right? Depends on the cause, severity, the patient, the available expertise.
Precisely. It's a complex equation every time.
And the field keeps evolving, more endo techniques, unexpected challenges like COVID. So here's a final thought for you, our listener. Given that amputation and mortality rates are still stubbornly high despite all these advances, what do you think are the most promising future directions? Where should research focus to really move the needle on outcomes in this tough area of vascular medicine?
Definitely something to ponder. There's still so much room for improvement in managing this serious condition.
Thank you for taking this deep dive with us today. Until our next exploration.